to follow time limit. Thank you very much, Professor, for the wonderful talk, and we are moving forward. I have pleasure to invite Dr. Tanya Kourtidou, pediatric cardiologist, with talk role of preoperative cardiac MRI in congenital tricuspid valve anomalies.
Good afternoon. Thank you very much for the kind invitation to be among all of these amazing colleagues. I don't know how I can top up the previous talk, but I will discuss how CMR contributes to the preoperative management of the tricuspid valve, and particularly in the congenital heart disease populations. I have no disclosures, and I'll focus on what questions the surgeons need to be answered before the operation, how CMR quantifies TR and RV remodeling, particularly in congenital specific considerations like Epstein as well. There will definitely going to be some overlap. And all the information presented are supported by recent guidelines and landmark research papers on the role of CMR. So while echocardiography remains the first line, CMR is most useful when the information is provided is insufficient to answer the three questions that drive surgical decisions. So how severe the tricuspid valve regurgitation is quantitatively, how has the right ventricle responded to that volume overload, and if there is any hidden or added surgical risk. That becomes particularly important in patients with poor acoustic windows, multiple interventions, complex anatomy, multiple jets, etc. And we have a stack of valuable imaging methodologies called sequences to assess anatomy, acquire volumes and flows, assess myocardial function, depict the entire thoracic anatomy through angiography, evaluate myocardial deformation and viability, do tissue characterization with mapping. All the following three categories of information can be obtained in a single exam. And first, we evaluate the valve anatomy and the mechanism to the best of our ability through MRI. Second, we evaluate the right ventricular response to that. And third, we are enabled to estimate the tricuspid valve regurgitation volume in the presence of associated lesions, such as pulmonary regurgitation, concomitant shunts, etc. In terms of valve anatomy, well, we try to answer if the primary leaflet, if this is a primary leaflet disease, or it could be secondary to, for example, pacemaker lead related issues. What the annular dilation is, and if we can help to size the ring, or if there's any congenital dysplasia where the CMR has a predominant role. This is a still image from an en-face view where you can recognize the saddle-shaped elliptical annulus of the valve, the septal leaflet closer to the septum, the longest anterior leaflet closer to the aorta, and the shortest posterior inferior leaflet closer to the coronary sinus. However, when it comes to leaflet evaluation, as it was pointed out nicely earlier, echo and particularly TEE has better spatial resolution for thin, hypermobile, or degenerated structures. Looking at a four-chamber cine view of a 12-year-old with Epstein anomaly, and you may recognize the severely dilated right atrium due to the atrialized portion of the right ventricle. Right below is the small functional right RV with the severely apically displaced and foreshortened septal leaflet that has restricted motion and results in lack of central coaptation with a long and sail-like anterior leaflet, and therefore results to tricuspid valve regurgitation. There's another way to interrogate the valve. Here's a stack movie of the inflow and outflow portions of this tripartite RV in the same plane. demonstrating also the hinge points of the leaflets. And as it was discussed earlier, by identifying those hinge points, we provide the surgeon with the Epstein valve rotation angle, like the EVRA, defined as the plane of systolic apposition between the anterior and partially laminated inferior leaflet in the long axis. So essentially, we measure the displacement, the rotation of the anterior leaflet and the annulus into the RVOT. And the bigger the EVRA is, the higher association with repair tension and dehiscence. And the number that has been used in research is anything beyond 50 degrees or 60 degrees has predictive value of lower success with cone operation. But in predicting success in cone operation, we also need data about the right ventricular response. And perhaps the most important contribution of CMR is the accurate RV remodeling assessment through not only end-diastolic and end-systolic index values and ejection fraction, but also by assessing the RV shape, like there is a basal dilatation versus global dilatation, the right atrialized portion, the volume in Epstein situations, and the RV strain and deformation. Due to the altered geometry, particularly in Epstein's, the volume should be confirmed in two different planes by taking multiple slices, both in short axis and axial or four-chamber cinestack acquisitions. And there are several qualitative and quantitative indices to appreciate globally the functional portion of the RV. But overall, we try to report not only the functional RV, but also the total volume of the anatomical ventricle. So on the top, you can see the slices of the ventricles in multiple levels in the short axis to produce the volumes and the function. And then below is the report, and I apologize for some Greek wording in that. Essentially, it's on the top is the left ventricle, and then the left ventricular volume indexed, and below is the functional RV and the total or anatomical RV. And you can appreciate that the total anatomical RV is 3 times the left ventricle, while the functional RV is twice the volume of the left ventricle. The end systolic volume indexed and the RV function are also critical parameters in driving timing of the intervention. And that is because early surgery before irreversible right ventricular dysfunction remains the goal. And because the RV function often lags behind volume load, you need to consider CMR strain when the EF is borderline normal. And tracking the patients along the time through serial CMRs has significant value. Look for disproportionate increase in the RV and systolic index volume with concomitant decline in the RV ejection fraction, because that suggests reduced reserve for the RV. And then keep an eye on the right atrial volume, the septal interaction, the left ventricular compression, and the caval dilatation. All of these are markers of systemic congestion that matter for perioperative management. Less than a year ago, the American Thoracic Society agreed that the decline in CMR derived by ventricular ejection fraction is an independent predictor of major adverse cardiovascular events in unoperated patients. And when you start to see that decline, you may need to consider 1.5 ventricle repair or even transplant when the left ventricular ejection fraction is affected. Now moving on to hemodynamics and measuring the tricuspid valve regurgitant volume. Why it matters? It matters because, like I said, and the previous speaker said, it affects mortality. So this is the largest outcome study with more than 550 patients on the natural history of tricuspid valve disease that links the CMR-derived TR volume and regurgitant fraction with mortality. And there are specific cutoffs, so the risk is low when your tricuspid valve regurgitant fraction is less than 30%, but you are on the high end if your tricuspid valve regurgitant volume is more than 45 ml, or essentially more than 50% of regurgitation. And these data support that this quantitative threshold of severe TR is related with progressively worse survival with increasing severity. How do we measure TR? Well, the traditional CMR approach uses the indirect volumetric method, where the TR volume equals the RV stroke volume minus the pulmonary forward flow. And the TR fraction equals the TR volume divided by the RV stroke volume. But this approach works well when the pulmonary regurgitation is minimal and there is no major intracardiac shunt. But the interpretation must always consider the broader hemodynamic context. So it does happen to encounter discordance between assessments when the TR grading on echo is more than moderate, or if there are intracardiac shunts contaminating the valvular flow. Here is a patient with a mildly dysplastic tricuspid valve, and these are phase contrasts, so like flow movies of the tricuspid valve and the mitral valves and FAS. The blue color is the blood that is coming into the ventricles, and the red color, so in diastole, and then the red color represents the regurgitant flow from the tricuspid valve that goes away in systole. But looking carefully, when you see in the middle the regurgitant tricuspid jet, you see simultaneously a blue jet. You simultaneously see a blue jet that represents an additional flow in systole that comes from the left ventricle to the right. It is essentially a ventricular septal defect, which is a small perimembranous VSD, partially occluded by tricuspid valve tissue, and it is seen here in the three-chamber LVOT view. You can see the involvement of the septal leaflet with redundant tissue into the VSD. So instead of subtracting volumes, we can measure flows separately, and we can measure the retrograde flow across the tricuspid valve, the specific VSD flow, the flow across the pulmonary valve, and essentially we can measure flow anywhere we want to. And aside of the flow volumes, we can appreciate the right atrial vortex formation and even assess energy loss through that whole process. So furtive flow is particularly useful in complex cases when you see multiple eccentric jets. And because we can produce flow diagrams like the catheterization cartoons, similar to the one that you see on the screen, we are enabled to assess the full heart flow, accounting also for SVC, IVC contributions, hepatic vein reflux, what's the differential pulmonary flow. And of course, there are several limitations in present, named like scan time, reconstruction time, analysis, but it's becoming an essential part of present assessment of and preoperative assessment of the tricuspid valve. Important to note that numbers are always just numbers, and interpretations should incorporate findings and symptoms. And occasionally we find like severe TR that has to do with respiratory patient variation, for example, and we cannot just call it. It's not a jet label. It's also a combination with the whole picture in the patient's clinical presentation. Moving on to tissue characterization, it is not the primary indication for CMR in tricuspid valve pathology, but it can add context. And that's because the late gadolinium enhancement may indicate fibrosis, like scar tissue at the RV insertion point. That's a marker of mechanical distress in the right ventricle. scar at the atrialized portion of the right ventricle or scar in prior surgical locations. And that has a potential for like arrhythmia substrate. This can also guide surgical strategy with resynchronization, biventricular pacing, or ICD placement that it was mentioned before. In terms of mapping and extracellular volume, they represent fibrosis, and at this point in time, we use them for like research purposes mostly, or myocardial deformation, and T2 mapping that represents inflammation is uncommon as a primary tricuspid valve regurgitation driver. Now, don't forget the left ventricle. Essentially, right heart deterioration is a left heart disease. And like it was presented before, the ventricular interactions are very important, and depending on the pathology, we tend to see different phenotypes. So Epstein disease has a different mechanism of interaction than the apical RV dilation that happens in repair tetralogy of Fallow, for example. And the left ventricular myocardial fibrosis, even if the function is still normal, is a marker of diastolic dysfunction that equals cardiomyopathy. Ultimately, our overall orientation for the CMR study is to help the surgeon understand if the repair is feasible, what the right ventricular reserve is, since dysfunction escalates risk, and if any adjunct procedures are needed. For example, does he need to close the PFO? Should he have a fenestration strategy? Or should he move on with the maze, and et cetera? I'm putting those numbers there as potential thresholds for TR. So with regards to ejection fraction less than 45% and end diastolic index volume of beyond 170, that means there is advanced remodeling. But there is no, be mindful that there is no single magic number and cutoff for volumes or regurgitation for TR for surgery in the guidelines. You need to take concomitant assessment of the trend, how the patient is like tracking, the symptoms, if there is any end organ dysfunction, and if the feasibility of durable repair is possible. Oops, sorry. A few take-home messages. I hope I was able to communicate that CMR is a one-stop shop. We assess anatomy, veins, pulmonary arteries, associated lesions, extracardiac conduits. It is a gold standard for RV size and function and a strong arbiter for TR severity when echo is discordant. 4D flow is helpful and is becoming an essential tool for us. Combine geometry, volumes, and flow to guide surgical strategy with patient symptoms, progressions, and resources at each location because, for example, transplant is not always potential wherever you are. These are the key guidelines and landmark papers supporting the role of CMR in tricuspid disease. And that was the end of my talk. It's becoming a navigation system, not just imaging for us. Thank you.
Thank you very much. We are moving into the next speaker, and we will leave discussion to the end of the